Hello, everyone. Thank you for joining us for the 20th consecutive week of our weekly briefing on preventing and managing COVID-19 in the workplace. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare. Thank you all for joining us once again, and for any of those who are joining us for the first time, we appreciate your participation. During this session, you will be on mute. Please use the Q&A function on the Zoom application to submit your questions, and we'll address as many as we possibly can in the time we have allowed for our webinar. We try to stick to about half an hour of presentation and 10 minutes for questions. And any remaining questions we always answer in writing and post on our website, which is on our COVID-19 page. You can find that at www.workcare.com. And on the homepage, you'll see the COVID-19 link. You'll also find a lot of other related resources on that page. And we post the recording on our YouTube channel. During the session, Alexis will post both of the links to those resources. Our speaker today, as always, is Anthony Harris, MD, MBA, MPH. Dr. Harris is our Chief Innovation Officer and an Associate Medical Director for On-Site Clinical Operations. He's our lead clinician for our COVID-19 response. So I'm going to turn it over to him so he'll have enough time to get through all of your questions and his presentation. Thank you, and thank you, Dr. Harris.
Excellent. Hey, thank you, Karen, and thanks everyone for joining us once again. Celebrating number 20, right? 20 consecutive webinars. We're certainly grateful for the opportunity to continue to present this data to you in regards to updating on the latest and greatest on COVID strategies to help protect your workforce. So without further ado, we'll jump into today's presentation here. And when we talk about today's focus, we're going to talk about really focusing in more from a regulatory standpoint. What are some of the things to keep in mind as we try to protect our workforce so that we're not crossing any barriers, any lines in basically from a compliance and legal standpoint of what we can and can't do. And then additionally, how do we leverage resources that we can provide at WorkCare and otherwise to help find either workarounds with regard to those regulatory hurdles or frankly, just best practices in regards to partnering with your local healthcare providers, your OCMED specialists, and the like. So we'll start with the same format as typical. If you're joining us for the first time, welcome. The format is pretty straightforward. Clinical update first, followed by pathology, microbiology update. We'll get into the epidemiology, both from a macro global as well as US-centric focus. And then we'll go into prevention. What are the issues around, in this case, again, the regulatory piece and some of the strategy we employ at WorkCare to help with our clients in regards to being compliant and moving forward through this pandemic. Now, keep in mind, as these things evolve, right, in regards to the regulatory status as we exist in this COVID world pandemic, we're going to be in this for some time, right? The foreseeable future is until next year that we'll have a vaccine that's widely available. We've updated on vaccines, and certainly we've updated on the prospect of how long we're going to have to deal with COVID. And it's going to be most likely, if not 10 months, 12 months from now, that we're going to be dealing with this. So our strategy has to obviously evolve, but we immediately have to make sure we're employing all the tools we can and leveraging our resources in compliance with state and federal guidance. So when we talk about our clinical update for today, nothing new under the sun for clinical presentations, right? But one of the things that we want to pay attention to as we speak to state and federal regulations, we're seeing states across the board starting to re-enter a period of increased restrictions, right? And so in this case, Oregon, the governor as of last week is announcing new restrictions to expand and include a wider range of age groups that need to be compliant with wearing face masks and a number of other measures to help fight the rise in transmissions that we're seeing across the board, okay? And so we know a number of states are doing this. We reported last week that Virginia was the first to pass legislation with their state OSHA, essentially to mandate protocols in place for all employers. And so we'll continue to provide those updates to you. So when we talk about now then pathology, there are some interesting things that have surfaced in terms of communication of risk, right? And it's not brand new in terms of this being mentioned for the first time. In this case, we're going to focus in on the ABO blood group. So we all should be familiar with blood types, most likely. Your A, your B, your AB, or your O. So these particular blood types have been a focus of interest both recently as well as back in March, as early as March, as to the risks of individuals contracting COVID-19 because of their blood type, okay? And so this article back in March was published, and this was data out of Wuhan, China, 2,100 patients roughly, and they looked at, in Wuhan, the people who were positive for COVID-19 confirmed with what was their blood type, and was there an increased risk or decreased risk for individuals who had a certain blood type. And what they found was that those who had a blood type of O had a lower incidence of being positive for COVID-19 as compared with those individuals who did not have an O blood type. Another study, this study was done more recently, data coming out of coming in June, looked at 1,980 patients. And these patients were individuals confirmed with COVID, SARS-CoV-2 in Spain and Italy, in the epicenters there, that had respiratory failure. And as they looked at those individuals and examined their blood type, they found that those who had A positive had an increased risk for being positive with COVID-19, and those who had O blood group had somewhat of a protective effect. Okay, so this is interesting data that we're finding, and we continue to see interest in this in particular. If we look at some commercial research, right, the two publication, or the two articles I mentioned just now were still pre-publication, not finalized through their peer review process. However, we're seeing now some data coming out of the private sector. 23andMe, one of the largest genetic organizations for helping people uncover what is their genetic profile, published back in June an association they found with blood type and risk for COVID. Now, this is a huge number of participants that they've had. They looked at over 750,000 participants initially, narrowed that down a bit. But at the end of the day, what they found was that individuals who had an O blood type are between 9 and 18% less likely to have COVID positive status than those who don't have O blood type. Okay, and obviously, and rightfully so, we're always a little suspicious about commercial research, right? When we talk about or private research, when it comes to commercial organizations. And in this particular case, this company did not have a kit or any kind of commercial solution for uncovering one's blood type. So that's good in a way. They weren't trying to promote one of their products at the time. But if we look at then more established organizations, in this case, Harvard School of Medicine, they wanted to kind of put a nail in the coffin, if you would, around is there not some associations with blood type. And what this study found when they examined from several major hospitals in the Boston area, and they looked at over 7,600 patients who were tested for COVID-19 and confirmed positive. And they found essentially that there was no correlation between severity of COVID, right? They were looking at the endpoint of, did you require intubation or did you require significant support in the ICU, or was there death, right? Was there a mortality involved? And with those endpoints, they found no correlation between blood type and severity of outcome. However, what was interesting is that they did find support for the protective factor of O blood type, right? So they suggested that more research is needed, we agree, for uncovering that association between the O blood type and risk of being COVID-19 positive. But certainly across these examined research publications, we're seeing that common underlying theme. So we'll continue to pay attention to it, as obviously this may have some ultimate impact to how we can protect our workforce by uncovering what is a mechanism by which people with O blood type are being affected with that level of protectionism, if you would. So when we reach into the epidemiology on a global standpoint and US focus here, we'll update, as we normally do, our numbers here first in the US. This was 2 weeks ago at 3.3 million cases. Last week increased to 3.8 million cases. And now we're at 4.2 million cases. Pardon the typo there on the date, but this is accurate data as of today. 4.28 million cases in the US. If we look at deaths, deaths are at 147,000 deaths at this point in time. This was 2 weeks ago. Looking at now the map of which states are suffering from the highest mortality. We saw 2 weeks ago this picture with Florida being added in terms of what we're seeing today. Now we're adding Texas and a couple other states to that threshold of having more than 5,000 deaths. And so we see in these numbers a correlation as well to those states that are instituting more controls, right? We know that Texas is now entertaining kind of a re-shutdown, if you would, for the state. And so we just need to pay attention, because obviously that will impact in a significant way our operations as employers. And we want to make sure that when these controls come into play, we have the appropriate processes in place to mitigate being shut down by the state or otherwise. As we look then to the trend, reported data from CDC, 7-day rolling average is that orange line that you're seeing there. Our cases as they were 2 weeks ago, as they were a week ago here, and then as they are today. We're still seeing that rise. We may be starting to see a slight leveling off of the number there. Still obviously a high significant number in terms of increasing cases on a day-by-day basis. But we'll continue to look at this new case rate here across the board in the US. As we compare then ourselves to other countries, we're still obviously on the rise in terms of number of cases. Looking at the 7-day rolling average, this was as it was 2 weeks ago, as it was last week, continuing to see an uptrend in that rate of cases. And then we're starting to see that similar pattern of perhaps leveling off. It's still obviously gaining in number of cases, but not having the exponential increase that we saw starting a month and a half ago. When we talk about deaths and the correlation of mortality with regard to increase in number of cases, reminder that there was some suspect that there was not an increase in mortality as it pertained to increase in cases that correlated to increase in cases. We disproved that with examining this chart and tracking along with the bump 2 weeks ago or several weeks ago that we saw the increased trend last week, and then we're still seeing an increase in mortality this week as well. We're not seeing a leveling off of mortality. So we do anticipate as we move through the rest of the summer into the fall to be still an increasing trend in mortality on a 7-day rolling average here. We'll look at this and we're revisiting this data, but this is a new chart this week to understand our share of daily positive tests. We're just presenting it in a different way this time because we want to examine how we're doing with regard to other countries that are either experiencing poor performance in terms of number of cases as we are, or they're doing well in terms of decreased cases. Okay, and so this is a 7-day rolling average in terms of how many cases are positive for the number of tests that are being conducted for COVID-19. And you can see there that we're number 7th in terms of positive cases, percentage of positive cases. Now, what that means is, again, that we have some ground to continue to make up for the estimation of disease of COVID-19 in the US. And if there's any doubt to our performance of articulating accurately the level of prevalence of disease, this chart should help uncover that. So this is the number of tests conducted for confirmed cases of COVID-19. And what you'll see is the inverse of this chart versus the previous chart. Norway there being on the bottom of this chart, meaning that they have a low number of positives for the number of tests that they're conducting proportionally. When we go to the next chart, total conducted COVID-19 test and the confirmed COVID-19, we're seeing them at the top. And all that means and all that suggests as we examine this is that they're doing well. Norway is doing well with regard to number of tests that they're able to conduct and the accuracy to which they're estimating their prevalence. Again, US being further down, kind of in the middle of the pack there, meaning we have some ground to make up for sure. When we then talk about our capacity for testing, we haven't examined this metric in some weeks, but we wanted to come back to help help everyone understand where we're at, right? How we improved in terms of the number of tests that are available. As we know, that's still a very bottlenecked resource, right? Some reports, if you look at parts of Florida like Miami, where the lines are literally hours and sometimes days long to get tested in South Miami, we know that we still have some ground to make up, but what do the numbers say? Have we improved? So right now, US, as we look at North America, we're right at about 150,000, a little over 150,000 tests available per million of our population, okay? So for comparison, where were we about 2 months ago? Back in May, we were at the 50,000 mark, okay? And so obviously we've improved, but again, going back to the 2 previous slides and that metric of where we're at as compared to our counterparts abroad, we have some ground to make up for sure. So we want to continue to watch this and we want to ensure that we're able to keep up and improve our performance. So now let's move to prevention and what do we need to be cognizant of from a regulatory standpoint, okay? Now, obviously we won't go into every nitty-gritty piece of legislation that pertains to what we're able to do in regards to COVID-19, but we want to be cognizant to what is relevant for helping keep our workforce protected and find that balance between protection and crossing the line of what we can ask of employees and what we can require to help keep them safe from transmission in the workplace and otherwise. So the EEOC has been opining and laying out for us a roadmap, if you would, of what can be asked, what cannot be asked, and we will obviously continue to pay attention to these regulatory declaratives, if you would. But it started way back in February and March, right, in terms of EEOC being specific to address what employers can do. And we have seen publications from EEOC to help when we talk about pandemic preparedness. If you haven't had a chance to examine this document, that was published around ADA. It is a valuable tool back in March to help outline our game plan for being compliant with not crossing the line, okay? And this playbook is not de novo, so to speak. They didn't create this specifically for COVID-19. What they did was use other pandemic documents they've created and guidelines that they've created, and they updated it with COVID-19 relevant information. Okay, so dealing with pandemics like the flu, swine flu, H1N1, right, was not the genesis, but the base for some of these updates here with regard to what employers can do and ask. And as we look at then what's relevant for kind of one of the hottest topics today, the utilization of different diagnostic tests and other COVID-19 tests. And so we want to update that around antibody testing. We know antibody testing has received scrutiny both from CDC and some of the clinical community around its use. And we know that the performance, as we reported on months ago, of antibody tests has been poor initially, but has improved over time and now has a significant efficacy if the test accuracy can be confirmed for understanding an individual's experience with COVID, right? Have they had it in the past? But what we need to know is that employers cannot require antibody testing as a predicate to return to work, right? And if you are, in terms of your strategy, and we certainly have spoken with employers that wanted to employ antibody testing in their strategy for return to work or a post-offer standpoint, we're recommending that, hey, we can't do that, right? As a requirement of the employment status. But there are strategies that in which antibody testing can be utilized, and we'll touch upon that here shortly. The other thing to note is that there is clear, again, reaffirmation that the diagnostic testing that is not antibody, right? That's molecular testing, that's antigen testing, free and clear. We're able to do that as an employer. We're able to ask that status because it reveals what is the current state of that individual as it pertains to COVID-19. Now, if we dig deeper and try to understand from whence these recommendations from EEOC come from, it's all predicated on what CDC recommends, okay? So CDC at this point has not endorsed use of antibody testing for understanding an individual's status for COVID-19. Now, whether you consider that to be political, whether you consider that to be scientific based, it is what it is, right? CDC does not recommend it, particularly in isolation for trying to understand status. But again, they also don't recommend any diagnostic test be used without clinical correlation by a physician or clinician to help understand someone's status. Nonetheless, we believe that once CDC comes around to endorsing antibody testing, this EEOC recommendation may be updated and may become a tool that is more readily supported in regards to what employers can do. Now, when we talk about clinical decision-making, antibody testing, we'll talk about antibody testing can still play a considerable role. When we look at what states are doing from a regulatory standpoint, they are issuing not only the kind of they're not only promulgating legal compliance in an emergency fashion as Virginia has done, as Oregon is preparing to do, and other states as well, but they also are publishing what are called playbooks or best practices for employers. So keep that in mind, pay attention to what each state is publishing because these will be relevant for our moving forward with good protection as well as good compliance. And certainly we're keeping abreast of these guidances so that we can offer these best practices to all of our clients across the board. And so when we talk about our strategy, there's things that we want to really focus in on in terms of what we can ask, what we can use, what we can't, and why we care, right? So when we look at from a charge of the employer to first and foremost protect their employees so that operations can continue and the business can thrive as a going concern, pre-existing conditions play a key role in that. Right? We know and we've opined about, presented facts on those who have pre-existing conditions can have poor health outcomes when it comes to COVID-19. And so understanding how to keep those members of your workforce, particularly if they're a critical worker with critical processes that are essential to your business, how to keep them healthy and protected plays a role in understanding their pre-existing condition, right? But we can't screen for these workers. And we even as As recent as today, I had an employer say, look, we want to screen and help protect those who are most at risk, right? By understanding, do you have diabetes? Do you have history of cancer? So those questions are a no-no, right? We can't ask those questions as an employer. But it is important in terms of prioritization of presenting protection strategies to the workforce. Even the federal government and the White House published guidance on how employers can protect workers as the different phases progressed to reopen the economy, right? And one of those key bullet points was keeping those workers with pre-existing conditions out of the workforce for longer. But again, understanding who and who does not, if it's not volunteered, is a conundrum, if you would. And so when we talk about our ability as clinicians to assist in that, we'll give you some insight there in a second. So the second piece of this is transmission risk, right? What is relevant from a regulatory standpoint of what we can and can't do, and we talk about sick contacts and household members being data that's important, but being in perhaps that gray area of what an employer can and cannot ask, right? We know that if you have a sick household member, you have increased risk for contracting the COVID-19, increased risk for potentially transmitting COVID-19 in the workplace in particular. But again, going into depth as someone's grandmother who's living with them is immunocompromised and has had COVID-19 is that area in which it may cross the line of what we can and cannot ask in the employer setting for our workforce. But again, relevant to making a determination on, is that worker able to come back to work because they don't need to quarantine, or do they need to stay out, right? And then when we talk about finally the return to work piece, pre-existing conditions come back into play, right? Those individuals, as we're seeing more and more of this, those individuals with pre-existing conditions or otherwise who test positive for COVID for prolonged periods of time. And now they're being required, if they're required to have a negative test or 2 negative tests 24 hours apart, right, as part of CDC still recommends in one of the pathways, they may continue to test positive because of pre-existing conditions. And again, we're prohibited for asking those questions as an employer. Now, when we talk about how do we still utilize the best practice and the utmost protection by being compliant, that's where you rely on us as clinicians, right? As we partner to provide not just in the screening modality, questions that we're able to ask as clinicians to make a determination of someone's status, right? But we're also through the contact tracing able to ask those questions around family members, around sick contacts and household members, and we're able to go deeper into understanding what is the true risk for this individual, what is for contracting COVID-19, what is the true risk for this individual transmitting COVID-19 because of pre-existing conditions and a potential positive status for longer, et cetera, right? And so putting the burden back on us as your clinical partner is appropriate in the strategy for making sure we can leverage all the tools available to us in the knowledge base that we have around COVID-19 without any risk of being non-compliant with state EEOC ADA regulatory guidance, right? And so it really is this holistic picture of the COVID surveillance that we've talked about before, from screening to time at home quarantine, doing a diagnostic test, whether that be molecular antigen or antibody, because again, if myself as a clinician orders an antibody test to help determine the status of an individual, that is okay, right? And so we can utilize that data as clinicians and provide you the results of this person is clear or not clear, and we're utilizing all the tools in our tool belt and not limited by what EEOC and ADA has put forth. Again, local testing and then return to work process all falls into place in alignment with the protocols and the guidance that we've been providing for several months now. But again, as the landscape changes, we'll update these. And as we're able to ask more questions, perhaps even from a employer standpoint, we'll let you know, right? And we'll be continuing to partner to go deeper in those areas where you as an employer are prohibited from going deeper so that you have best practices in place. So again, we're gonna be dealing with COVID-19 for some time. We're gonna make sure that you have the best practices in place, and we're gonna make sure that you're compliant, not just from, again, EEOC ADA, but those state compliant issues we mentioned last week, right? And if you're in Virginia and you don't have certain measures in place, you can be fined by the state up to $130,000. Right. And so these penalties will become significant for employers in many areas as states continue to promulgate this emergency legislation to help protect transmission of COVID-19 in the workplace. So with that, I will wrap it up and we will open it up to questions. Thank you, everyone.
Thanks, Dr. Harris. This is Karen again. Lots of questions. One person's asking for a link to one of the documents you referenced, which we'll provide. It's on the slides, so we'll make sure everybody gets that. So just answer that question. I wondered if you could elaborate on the pre-existing condition screening if an employee voluntarily tells the employer they request an accommodation for a disability or they have a chronic condition that may affect their performance. In what ways can the employer assist that person because they have revealed that they have this disability and have asked for assistance? Does it make a difference in the way you would handle their return to work or screening for COVID?
So yes, so if someone voluntarily communicates their pre-existing condition, or particularly they ask for accommodations, then the classic game plan for accommodations with regard to those with disabilities plays out, right? And so the employer will keep that in a confidential file, HR file for the individual, and those accommodations should be considered, right? And when we talk about COVID-19 in particular, yes, determination should be made in conjunction with your clinician. Is this individual okay to come back to work given the current state of local transmission and a risk of workplace transmission? So it may play out that because of pre-existing conditions or disability, an individual is not ready for a return to work re-entry because of the relative risk for that particular scenario. As opposed to if an individual without a pre-existing condition may be okay to come back into that scenario. And it's going to be a case-by-case determination, and that is permissible with the guidance that we currently know to be true from ADA and EEOC.
Okay, thanks for that answer. That was kind of something I was curious about. So, you know, the CDC made a change in its guidance recently, and I sort of anticipated we'd get a couple questions about it, and we did. So I'll try to summarize the ones we got. The CDC has updated its when to end home isolation guidance and now states free of fever for 24 hours versus 72 hours and improvement of symptoms versus improvement of respiratory symptoms. They also are not recommending a test-based strategy to return from isolation, but rather now recommending symptom-based strategy. The question is, what is your opinion about this change in their guidance?
Absolutely. So the change in the guidance we opined about a little bit last week in regards to the update from CDC. And so I'd like to actually present that now, and I'll throw that up on the screen here for everyone to see. Let's see here. We'll throw it up here right now. So beautiful. So those recommendations came as a result of data that we've seen from and presented by CDC. And those recommendations, let's see, actually that was two weeks ago that I think we presented that data here. So apologies, I wanted to show you on the screen for everyone to see, but I think it was, oh, sorry, no, that was the, well, anyway, let me give you the answer to the question here. So the answer to that question is that the data that the CDC utilized and presented to make those updated recommendations came from several studies some of them pre-published studies. Nonetheless, those studies presented results that showed one, individuals have recovered from COVID-19 and no longer have replicable competent virus, meaning that when they swab those individuals that have had confirmed COVID-19 10 days after their symptoms presented, none of them had virus that could replicate and cause a transmission to someone else. Okay, and there's a couple studies to support that. Secondly, they reinforced their guidance, looking at studies that examined what was the risk, particularly in a healthcare scenario, that an individual would contract COVID-19 if they encountered someone who was confirmed positive 6 days after presentation of their symptoms. Okay, so put another way, if I'm patient 0 and I have COVID-19, what is the risk that I can give COVID or transmit COVID-19 to someone else 6 days after onset of my symptoms? And the answer and the result of that study was 0. There were no cases in that particular healthcare setting of an individual contracting COVID-19 from someone if it had been 6 days after the presentation of the patient zero's presentation of their symptoms. Okay, so because of that, CDC updated their guidance, and we agree, based upon review of the literature there, that the risk to an individual of contracting COVID-19 from someone, if it's been 10 days since onset of the symptoms or 10 days since a positive test, or even even shorter in some cases, is low. So we recommended, and consistent with CDC, the return to work scenario with that 10-day marker. Now, we also understand that some employers want to be a little bit more conservative still, and that's fine, but we do want to make sure we're keeping abreast of best practices, evaluating CDC, WHO, and other resources for what should be the best approach to maintain health in the workforce.
Okay, here's a question that refers back to your discussion about the protective factor for blood type O. And the question is, what is the possible protective factor for the MMR vaccine that may have an impact on whether or not it affects children and protects them from coronavirus?
So I am not aware of any peer-reviewed literature correlating protective effects of MMR on COVID-19. With that level of interest, though, we'll do some research and perhaps present on that in a coming webinar here. But as of right now, I'm not familiar with any peer-reviewed literature that supports those type of findings. Okay,
and we have time for one more question. We're evaluating the protection measures for the return of employees who are now working in the home office. Should we be concerned with air exchanges indoors or using a mask, distancing, alcohol gel? Are they enough? Are there any risks regarding the concentration of air in the environment? There's also two other related questions. One's about wearing a mask that has a vent versus one that doesn't, to help people when it's really hot and humid so they can breathe better. And another one about brushing teeth in a communal bathroom at a work site. So they're all kind of related to what precautions should we be taking.
Got it. Okay, we'll try to keep this succinct here. As opposed to, so in regards to masks with vents, don't use them. If they have a vent, that means there may be a port that does not have filtered droplets exiting from the individual wearing it and passing to others. So do not use any kind of masks that have vents, the ports on them. Now, in regards to the air exchange, quickly, the brushing the teeth, haven't seen any studies that address any increased risk with airborne viral contamination by brushing teeth, right? Certainly those activities that are like singing and a lot of speaking in close proximity to others, but nothing around brushing teeth. When we talk about then the risk for individuals with regard to the air movement and concentration of the air, et cetera, air cleaners. So we know several things, right? We know that turning over the air in a facility can benefit the amount of particulates in the air. And if it's not too onerous of a business process, then instituting that can only benefit and not harm, right? And then, but again, it's not the level of protection that is necessary in isolation. You still need to do the distancing, the hand washing, hand sanitizer, the masks, face coverings. And so again, let's call it contact distancing or physical distancing. And then when we talk about air purifiers, HEPA purifiers are beneficial for removing viral contaminants from the air. A lot of facilities don't have that, but if you can update to the HEPA filters, again, can only help in those scenarios, but it will not offer an absolute protective factor in terms of removing the necessity for those other protective measures that we know are very effective at reducing transmission.
Fortunately, we're out of time. There's never enough time, but we look forward to everyone joining us again for week 21, same time, same place. Thank you all for joining us. Thank you, Dr. Harris. Everyone stay safe, wear your mask, wash your hands, and take good care of yourselves.
Excellent. Thanks, everyone. Stay safe, and we'll see you next week.